the president of Apollo Telehealth Foundation India. Professor Ganapathy will be taking us through demystifying the telemedicine guidelines that were recently announced by the Ministry of Health and Family Welfare. The significance of telehealth possibly a few weeks back, an explanation to do, but given today's situation and a complete lockdown of almost every service that is there, the need for telehealth is very obviously understood, and also the need is in a demand. In this situation, almost all of us, either as clinicians or administrators or members of organizations who are leading the digital and telehealth practices, are required to advise our organizations on how to take telehealth forward. Telehealth clearly provides all of us the platform so that access to healthcare and the reach to healthcare and the ability to get talent from wherever it's available made.
At the outset, I wish to thank Chime India and the Tamil Nadu chapter of the Telemedicine Society of India for inviting me to demystify, as it were, the telemedicine guidelines notified by the Government of India on 25th March 2020. Contrary to an erroneous perception, there have been endemics in the past. 102 years ago in Spain, the Spanish influenza came. Of course, the only difference is they did not have access to the technology which we have. If I were to ask you an MCQ, who you think was responsible for the notification of telemedicine practice guidelines? A. CMDs of hospitals. B. CEOs, CFOs, CIOs, the Telemedicine Society of India, and finally, our good friend, the coronavirus. We have to agree that number 5 played a very, very important part, though number 4 was equally responsible. If number 4 had not taken all the trouble it took, I won't say trouble, that's our duty. If number 4 had not made all these interventions for the last 2 years, number 5 would not have been able to precipitate this within a couple of weeks. Now, why is telemedicine particularly critical at this stage? A. We want to avoid people attending hospitals. As you can see from these visuals, coronavirus suspect patients coming to hospitals is the best way to ensure further spread. It also results in doctors themselves falling sick. Worldwide, telemedicine has made an exponential growth in the last couple of weeks. China, Australia, Hong Kong, every single country is now embracing telemedicine. The World Health Organization, the CDC, and most interestingly, the Government of India have all endorsed telemedicine. Trump, in fact, has sanctioned $500 million exclusively for the deployment of telehealth in the ensuing pandemic. Health insurance companies, particularly in the United States, have responded, and every single teleconsultation, not only in connection with the pandemic, but even for non-coronavirus infections, are now being reimbursed by every single health insurance company. This word cloud on telemedicine is self-explanatory. Most of the audience listening to this talk are familiar with words like electronic records, SMS, WhatsApp applications, tablets, and so on. Couple of days, it has been amazing to see the amount of awareness which many of us are trying to create using the media. Articles have come in almost all the national newspapers advocating the use of telehealth. It is in this background. Now, this slide, for example, I know that at least 50 to 60, maybe 100 or 150 hospitals have already got onto the bandwagon and have publicly announced that they are going to start, or they have already started, giving free consultations electronically. Now, why I'm giving you this background is very important before I go into the actual main part of the talk. Perhaps this will take a few more months, but this has already started happening in the rest of the world. Detailed clinical evaluation of a suspected coronavirus patient is possible. Not only can we measure the temperature with thermal sensors, the healthcare provider can be located several hundred miles away, and a paramedic or even the family member themselves can look peer into.
అది రాదు ఫైల్కి రాదు ఏంటంటే
Hello, can I continue?
ఇది వచ్చింది కదా
Yes, Dr.
So
Ganapathy.
please continue. All members kindly mute your lines.
Sorry?
షేర్
Will you please continue?
Okay.
Dr. Ganapathy, can I request you to minimize that window on the right side? It is masking
Because
part
there
of your
is an
presentation.
interruption which disturbs me.
Dr. Ganapathy, can you please minimize that white window on the right lower corner? We can't see
There is a
full
WebEx
screen.
reminder window, sir. Please minimize.
There is, oh, sorry.
Okay, continue, sir.
Okay, sorry. Yeah, go ahead. Okay. So as you can see here, a detailed clinical evaluation of a suspected coronavirus patient can even be done remotely. It is possible to peer into the interior of the throat. And I understand that a few robots have been used in trials in China where a robot can take a nasal swab, a throat swab. So this is where technology is today. Of course, stethoscopes, digital stethoscopes are freely available in the market. Respiratory sounds, preeminent pneumonia, pulse oximeter, ECG, speaker, webcams, etc. All these are available. What are the concerns which many of us have in deploying telemedicine before the guidelines were issued? The concerns included accreditation, authentication, authorization. Are we authorized to do this in the first place? And of course, confidentiality, EMR privacy, professional liability, and reimbursement. Many doctors in India were concerned that there was no specific guideline and were they breaking an unwritten law. All this has been set to rest completely. Again, before I go into the actual guidelines, it is necessary that we clearly understand the process of telemedicine. For telemedicine, I personally like the word telehealth, particularly in the coronavirus setting. I think medicine to me implies a one-to-one relationship between a doctor and a patient. Healthcare is much more important. It includes promotion of health literacy, counseling, and so on. So for a telemedicine unit to be set up, you require dedicated hardware, software, obviously connectivity. Connectivity can be of various types. It can be through VSATs, it can be Wi-Fi, it can be WiMAX, it can be internet, and so on. We talk about acquisition of images, storage of images, retrieval of these images, display of these images. This presupposes that the people using it have got some orientation, have been trained, and obviously one shoe does not fit all. Customization is required, and of course, a solution is not a solution unless it is universally available 24/7 to everyone. That means it has to be cost effective. We were worried whether we were compliant with regulations and whether there were any standards which we have to enforce. Of course, any project has to be self-sustaining and, most important, future ready. Now, I just want to spend 2 minutes to convince every one of you. I understand that a part of the medical community is still worried even after reading the practice guidelines. I would like to point out that legality of teleconsultation started as early as 1997. The laws of Malaysia was the first country to implement this. And I have highlighted in yellow on the top right-hand side, imprisonment of 5 years is the punishment given to a doctor who does not follow the stringent laws. If you look at Abu Dhabi, it is illegal for a citizen in Abu Dhabi to obtain a teleconsultation from any doctor. He could be the director of the All India Institute of Medical Science, it doesn't matter. No doctor who is not registered with the Abu Dhabi Health Association is legally allowed to give even a virtual consultation to any citizen of Abu Dhabi. These are the very stringent laws. I have done a reasonable study of at least 10 to 15 countries, the laws passed out in these countries, and I can assure every one of you that the telemedicine guidelines promoted by the Board of Governors is the most doctor-friendly guidelines which I have ever seen as of a few weeks ago. Now let's look at this. What happened just a few days ago? On the 25th of March, the governors who have superseded the erstwhile Medical Council of India formally notified in the Ministry of Health website what is called the Telemedicine Practice Guidelines. This enables registered medical practitioners to provide health care using telemedicine. I will now go into the minute details which I think are very vital for anybody wanting not just to embrace telemedicine, but even to join telemedicine. Within a few hours of the notification, no less a person than the CEO of Niti Aayog has tweeted, "Tough times call for innovative solutions. Now consult doctor remotely through telemedicine." Do you want a better person to advertise the role of telemedicine than the CEO of Niti Aayog? It is sad that it took a virus to make us reach this situation, but on behalf of the Telemedicine Society of India, we are extremely grateful to the authorities for doing things in record time. You can see here, Now, the Board of Governors, empowered by the Health Ministry to regulate, now every word which I read is important, to regulate practice, the practitioners of modern medicine, was published as an amendment. I want to reiterate, this is not a simple notification in a website. It is an amendment, a gazetted amendment, which is going to be gazetted very soon. An amendment to the existing Indian Medical Council Professional Code, Etiquette and Ethics Regulations 2002. This has given statutory support and today forms the basis for the practice of telemedicine in India. It is interesting that it was exactly on March 24th, 2000, I can't help with nostalgia recollect this, 20 years and 1 day to be precise, that the world's first VSAT-enabled village hospital at Araganda was formally commissioned by Bill Clinton, the then president of the United States. ISRO at that time played a major role in ensuring connectivity to remote parts of India. No doubt it took us 20 years and 1 day before telemedicine practice was legalized. But believe me, we are catching up, and I'm very sure that very soon we will be far ahead of most of the countries in the Western world. 3.8.1 clause mentions the consultation through telemedicine by the registered medical practitioner under the Indian Medical Council Act 1956 shall be permissible in accordance with the telemedicine practice guidelines contained in Appendix 5. I am interpreting this as to mean that this act at the moment does not permit Ayush, though the Prime Minister of India himself made a reference to Ayush practitioners to practice telemedicine for the pandemic. I presume that the Secretary Ayush would be issuing an appropriate notification. This notification covers those registered under the Medical Council of India Act. They shall come into force from the date of publication in the official gazette. That is what is mentioned in the actual notification. Now, again, you can see shall be permissible. Any practitioner today can practice telemedicine without secondary registration or without supplementary registration. This is to enhance health services and provide access to all in India. For a long time, for several years, there were concerns whether a doctor in Tamil Nadu registered under Tamil Nadu Medical Council could teleconsult a patient in Uttar Pradesh or Punjab or any other state. This has unequivocally said that under this law, anybody who is registered with any state medical council can legally offer virtual teleconsults to anybody residing in India. We intend to raise the point whether an Indian doctor, a doctor physically located in India, the law does not speak about it at all. Nothing prevents me as of today to provide teleconsultations to citizens and to individuals living outside India. Similarly, the law is silent about whether an Indian can teleconsult a doctor who is physically living outside India. The principal regulations were published. We are talking of the original regulations. You can see the various sections under which it was published. Now, what is remarkable here is, I don't think in the history of Indian independence, 73 years, has an order been passed within 24 hours, probably 12 hours of the ministry receiving a suggestion from the Medical Council of India. You can see I've highlighted in yellow how the Ministry of Health received the recommendation on 24th March and it is notified within 24 hours. It very clearly states, in view of the urgency, the amendment to the Indian Medical Council Act for providing statutory basis to the telemedicine practice guidelines is being placed on the website of the MCI for usage. Please remember, it is not for information alone. This is tantamount to an act or a bill passed by Parliament in the case of an emergency. It can be used as usage by the RMP under the Indian Medical Council Act. And the most important thing is the words usage, patients, and other healthcare professionals. This is a fantastic step. There are probably, I am not aware of any country which has officially said that non-medical, non-MDs, non-MBBS, nurses, paramedics, healthcare providers, the ASHA, the healthcare assistant, and what have you, these people are empowered by the law today to use a virtual teleconsultation. Within hours of this act being produced, many, in fact, most of the state medical councils have authorized the use of teleconsultation. We all know that health is a state care subject, and it is absolutely fascinating to see council after council issuing notifications, putting in vogue that from now it is legal to use teleconsultation. Now, I want to reiterate that the guidelines issued is not just a guideline. Don't go by the English dictionary or the word guideline. This is not notified under the Epidemic Act of 1897, nor is it notified under the National Disaster Management Act of 2005. These were some of the concerns raised in the last few years. This this guideline, I repeat, is not pandemic specific. It is here to stay permanently. Again, I want to reiterate that this guideline is extremely doctor friendly compared to the guidelines issued in most other countries. The amendment does not add any new requirement of registration for doctors who want to practice telemedicine and provide teleconsultation. Now, last year, a lot of confusion was created because the Karnataka State Medical Council even warned doctors in the state of Karnataka against offering online consultations and threatened cancellation of registration. This had a domino rebound effect, and we noticed that teleconsultations all over India fell because of this concern. Ladies and gentlemen, this has now become history. Now let's go into the details. Patient consent. Patient consent for a teleconsultation is implied if the patient initiates the teleconsultation. Again, there are many doctors who are afraid that it needs to be documented. How do I document a video consultation? How do I document a WhatsApp consultation, a telephonic consultation, etc.? The guidelines explicitly state that a patient consent is required only if it is a health worker who is initiating the consultation, or one doctor to a specialist or super specialist, or the caretaker. This is what I feel is absolutely fantastic. I remember over the last 20 years as a neurosurgeon, I have refrained from giving consultations to caretakers on the ground that you do not have a locus standi. How do I talk to you when you are not the patient? And this has always disturbed me. But the guidelines very clearly state that a caregiver has the right to ask and initiate for a teleconsultation. And for those of us who feel that we are doing a lot of paperwork, let me assure you, and I'm quoting from the practice guideline directly, all that needs to be done is for the RMP to record somewhere in his patient record the words, yes, I got a phone call from the patient's caregiver, Mr. So-and-so, that the patient wants to avail of a consultation. Something very simple, that's all that is required. Now, what are the types of consultation? First consultation, many of my colleagues, my other doctors who give teleconsultations refused to give a first consultation. They said, we have not seen this patient physically earlier. We will only do follow-up consultations. Let me remind them,
that the practice guidelines unequivocally, unambiguously state that a first consult. Now, please remember that a High Court, the Mumbai High Court and several other High Courts had on several occasions pointed out a question. They're not said it was illegal. Because there's nothing, no law to interpret. But the High Courts had pointed out, had questioned the legality of examining somebody virtually. And in several previous publications and presentations, I had repeatedly reiterated that today with modern technology, I can do a detailed physical examination of a patient virtually. I can even look inside the inside of his stomach. I can do a teleendoscopy. I can look at the fundus, ophthalmoscopy. I can do every single examination, colposcopy. We ourselves have done for cervical cancer screening more than 120 patients remotely, guided by an obstetrician from Madras. So this has been said once and for all. What does a doctor do when a patient comes to him in a face-to-face encounter? I listen to him, get a history. From the history, make a diagnosis. I mean, at least the old generation of people like me who insist on a detailed history. And then prescribing medicines is the last part, perhaps the least important part. The most important part is counseling, educating, discussing with the family what exactly the patient has got. Every one of these have been detailed in great detail in the practice guidelines. 5 types of teleconsultations have been described. Patient to registered doctor, which we are all familiar with. What is very important, particularly in the pandemic situation, is a third person. It could be a caregiver. It could be a health worker, somebody who's not related to the patient at all. But an ASHA today has the right to ring up, to speak, to send a WhatsApp message, to send an SMS, to contact by video, WhatsApp, whatever it is, to a registered medical practitioner. And finally, and this, I have no qualms in confessing that I had made a total mistake during the first 10 years as a telemedicine specialist. I started telemedicine in 98, and almost for 10 to 12 years in hundreds of lectures, I said telemedicine by definition excludes emergency. But over the last 5-6 years, I've been made to eat my words. My colleagues have shown that it is possible today to give teleconsultations for absolute emergencies. And I'm very proud that we run the world's largest 24/7 emergency center in the Himalayas for the last 4.5 years, and more than 1,400 emergencies have been attended. We did all this purely because we genuinely felt that whatever we are doing is in the interest of the patient. So this is one thing which I want to reiterate again and again and again. Whatever you do in the interest of the patient will be accepted. The guidelines is not a break. The guidelines do not mean to give you so much of problems that you're not going to do it. On the contrary, you do what is in the interest of the patient. No court of law will ever pass any strictures against any doctor, healthcare provider, health worker, caregiver, whatever it is, if something was done in the interest of the patient. All these guidelines are in this to be interpreted not as absolute law, but as guidelines. The first consultation between the doctor and the patient, I've already mentioned this, need not be an in-person consultation. Now, this is to be emphasized. The American Telemedicine Association has written several pages about this. Identification is mandatory during a teleconsultation. Identification of both the teleconsultant and the patient. Please remember that it's not at all difficult for somebody to substitute, and you think that you're giving teleconsultation to the person whose medical records you're seeing, but it may be somebody else. So may I request every one of you to ensure you can use an Aadhaar card, a passport, a traffic license, whatever it is, but be convinced that you are dealing with the right person. Similarly, the guidelines unambiguously state that the doctor should identify himself. I give a consultation to somebody doesn't like me, and he says, I am Dr. Ganapathy, neurosurgeon, and does some major mistake, and I will be penalized. Not only the question of my being penalized for it, the patient will suffer. Therefore, your registration number should also be displayed in a way that when a video consult is done, the patient at the other end knows precisely the credentials of the person who is examining him remotely. Doctors should maintain patient records of teleconsult. We are in a transition period. All transitions offer great opportunities. And I think that in the next couple of years, India should make use of this opportunity and ensure that 1.3 billion people have electronic medical records. Yes, it's easily said, it's going to be extremely difficult, but it is not impossible. Maintaining records of teleconsultations in the absence of a MPHR, a personal health record, a mobile personal health record will be extremely difficult. Though it may initially be difficult, it's very soon one will get accustomed to filling up all the columns. The medical informaticians of this country have done an excellent job in providing EMR. A doctor should not continue with teleconsultation if not appropriate. I would like to spend at least 3 minutes on this. Ladies and gentlemen, it's clinical judgment, clinical judgment, clinical judgment. It is your professional competence that you need to exercise for each and every single teleconsultation that you do. I'm going to show you a few illustrations and examples. Now, I'm an old-fashioned physician trained in the BC era, before computers and before Christ were one and the same. Let's say I make a clinical diagnosis of a possible prostate carcinoma in a 65 or 70-year-old male. I am old-fashioned. I would like not to entertain such a diagnosis without a rectal exam. But a 30-year-old doctor just returned from the United States, the UK, or trained in one of the big institutes in India is quite satisfied with a superb ultrasound. He says, why the hell should I do a rectal exam? The ultrasound very clearly tells me that he has got hyperplastic nodules on the prostate. Fair enough. He may diagnose a prostate SOL based on a teleconsultation, but an old-fashioned person like me will say, sorry, I cannot give an opinion. Please come for a face-to-face. In other words, clinical judgment. Now, I'm going to give you a few examples which I want you to remember. Even if you don't remember all the legalities, it doesn't matter at all. I repeat again and again, the legalities are only to convince the government, the authorities, that whatever you do is in the patient's interest. This was a teleconsultation referred to me more than 15 years ago from Port Blair, Andaman and Nicobar Islands, at that time certainly a desolate, isolated area. And obviously there was a swelling in the back. Any good third-year MBBS student would have made a diagnosis of a meningocele or a meningomyelocele. As a senior neurosurgeon, I had to take a decision within minutes and say whether the patient should immediately be put on the plane and brought here or what is to be done. So I did innovation, used my what I call native intelligence, which is becoming less and less with more sophisticated education. I told the nurse there to take a torch, remove the hood of the torch. This is how I was trained in Madras Medical College half a century ago. But this information was enough. I was very sure of my diagnosis. I said there is no spinal cord in this herniation of the meninges. Brilliant transillumination I see. And on pinching the legs of the child, it's a newborn child, so obviously the child will not cry, but there was some movement to the legs, and that was enough for me. And I said, look, this is not an emergency. Wait for a couple of weeks. It's unlikely that the skin will burst and the CSF will come back. And after a couple of months, send the baby to the mainland. Now, this is what I mean by a teleconsultation. So you need to use your clinical judgment. Of course, at that time, there were no rules. Now, here is an example. Ordinary phone, an entry-level phone. It is not even a smartphone. I never taught this person how to use a mobile phone. They asked me, and I insist that I must physically see a patient before I make a diagnosis and give an opinion. So I said, look, I understand the patient is not doing well. You can't come 300 kilometers to Chennai, but I must see the patient. So the patient's relatives themselves suggested, sir, we have some photographs on our mobile phone. Will you have a look at it? I said, yes, okay, good. But I need to know these photos were taken several weeks ago. I need to know how the patient is today. And I was absolutely amazed that he just took out his mobile phone, called one of his relatives there, and then did a video consult with me. I was able to do a detailed neurological examination of a patient in a small town with an ordinary entry-level phone. The uses of telemedicine are enormous. Now, of course, not everybody would agree with my decision here, but this was again from a village, and I knew this patient is not going to survive for more than 10 minutes or maybe half an hour. So I said, you document it, you write in the case records, discuss with Dr. Ganapathy, neurosurgeon, Apollo Hospital, Chennai. He is of the opinion that the patient is in extremis, unlikely to survive, and need not be transferred to a tertiary care unit. Exactly as predicted, within 30 minutes, the patient developed an irreversible cardiac arrest. I have a tremendous satisfaction of preventing the family from spending thousands and thousands of rupees in growing across border posts, going to another state, and so on. This young boy came to me for a teleconsultation. I examined him. There was no neurological deficit. The history suggested that he had a seizure. Now, I want to emphasize again and again that just like I do not want to miss a seizure or epilepsy, some type of epilepsy, I'm equally concerned that I don't want to label somebody as having epilepsy when he does not have this epilepsy. So this patient was from Dubai, incidentally. So I told the family, look, this is not a life-saving emergency. Wait for a couple of days. Whenever next time, when he gets what you think is not normal, just take a video and send it to me. And as you can see here, any MBBS student or even a non-technical person will make out a classical diagnosis of a type of sensory seizure. So this was what I wanted. So in other words, I delayed the teleconsultation by 3-4 days. So what I'm trying to emphasize is every patient must be customized to suit what he has. You must maintain the same standard of care during a teleconsultation as in a face-to-face visit. The TMG have clarified that the patient will be primarily responsible for the accuracy of information shared with the doctor. Caregivers are deemed to be authorized on behalf of the minor or an incapacitated patient. I think this is a very, very forward-looking step. Today, I can, with equanimity, talk to a caregiver, listen to the caregiver, look at photographs, asynchronous, offline, without necessarily directly examining the patient. So long as I'm satisfied about the authenticity of the caregiver and I'm satisfied as to the reliability of the information provided to me as a surrogate decision maker by the caregiver. This presupposes that the caregiver's identity and authorization should be checked. Compliance, adherence. This is not a typographical mistake. Documentation, documentation, documentation. Every one of this is important. Again, it is mandatory for doctors to prepare, maintain, and preserve the patient's records. Now, if any of you get frightened by these words and think this has to be done in a very, very formal way, not at all, at least not for the present. For the next couple of months at least, the authorities are not going to go through every single word you have written, but they just want to impress upon you the necessity to have a copy of the prescription used and a proof of teleconsultation. This can be a phone call history, this can be an email record, can be a chat or text record, video interaction logs, etc. And if you have an approved EMR, this will become routine and simple. A doctor should not deny emergency teleconsultations, but again, unless you're working in a quaternary care hospital like I am, and unless you have access to a 24/7 state-of-the-art emergency system, it makes common sense that every doctor should ensure that an emergency teleconsult is what the words mean, an emergency teleconsult, no more, no less. He must recommend, not only recommend, ensure that an in-person consultation is done at the earliest after your emergency consultation. But please remember, it is not illegal to give an opinion on a phone, on an email, everything. If you think it's an emergency, your opinion could just be, sorry, I don't have information, you must go to a hospital physically. That could be your opinion. Fair enough. Prescriptions. This is a major part of any consultant's job. Now, again, we used to have so many doubts. In fact, I myself, in so many lectures, I have said that a facsimile JPEG image is not correct. You need to get an encrypted digital signature, as we do for TDS or as we do for any under the IT Act. Today, the guidelines make it very clear that an image will suffice. So obviously, a JPEG image of your signature will suffice. Though they have recommended a prescription format, Medical Council of India, it is very difficult. You need to write down the symptoms, the signs, the diagnosis, etc., etc. I personally think it makes good practice to at least write down your clinical diagnosis. Now, you may argue that it is impossible to make a diagnosis based on a 10-minute clinical encounter. Absolutely right. But you should at least say NYD headache. That's what I do. Not yet diagnosed headache, which makes it very clear that I'm only treating a symptom, that I don't know yet what is the cause for the headache. Or I would say migraine, or I would put question mark migraine, or I would put to exclude ICSOL, intracranial space occupying lesion, and so on and so forth. Whatever be the diagnosis, you must have a working clinical diagnosis. You are liable to be taken to task if you give a prescription without a working clinical diagnosis. Again, the practice guidelines very correctly emphasize that a video examination must be done for prescription of most authorized drugs, including various scheduled drugs. It is not recommended that you give a prescription for a scheduled drug without a video examination. Of course, many of these things have to be reviewed, follow-up of patients. You must understand that this is 1.0 practice guidelines. I'm sure over the next few months, we will get enormous feedback, and the authorities will certainly take our views into account, and this prescription section will certainly be modified as and when required. This is just the recommendation of the Medical Council of India. Now, guidelines provide information on technology platforms. Not only provides information on technology platforms, but more important, the guidelines tell you how to integrate these technologies to deliver remote healthcare. It spells out technology and transmission of voice, data, images, and information. How all this should be used individually or in conjunction with other clinical standards, protocols, policies, and procedures for the provision of healthcare. And one of the recommendations made by the TSI has been accepted. Of course, if I remember right, we had suggested 1 year, but the authorities have said 3 years. An online program will be developed and made available by the Board of Governors. All current registered medical practitioners must complete a mandatory online course before March 24th, 2023 to be entitled to provide teleconsultations. And this is absolutely welcome. After 2023, you cannot, I repeat, you cannot enroll as a registered medical practitioner in any medical council unless you provide evidence that you also have gone through a telemedicine examination. I think this is fantastic, and I'm not sure how many countries have such a clause in vogue. Special exclusions. Now, equally important, the guidelines mention do this, do this, do this. But very, very smartly, they have not mentioned, they have not said it is illegal. They have just not talked about this at all. They have not given, it's outside the purview, in other words. They have not given specifications for hardware or software, for specifications for infrastructure building or maintenance. They have not mentioned anything about data management systems, their standards, and interoperability. These have been mentioned in other standards which are already in the public domain issued by the Ministry of Information Technology. But this MCI regulation is totally silent on that. Another very interesting point, I'm sure many of you remember, I think it was last year, and in near Ahmedabad in the state of Gujarat, invasive cardiologists claimed to be the first in Asia, did a remote angioplasty. It was a fantastic exhibition of technology. But as per the present telemedicine practice guidelines, you cannot use digital technology to conduct a surgical or even an invasive procedure remotely. Now, I am assuming that ophthalmoscopy obviously cannot be considered as remote procedure because we do remote fundus examination by the tens of thousands for state governments. But what could be considered as an invasive procedure is teleendoscopy or telecolposcopy, which we are now doing. So this procedure needs to be ascertained. This particular class needs to be ascertained. Again, I'm a little confused with this. It says under exclusion, research and evaluation of continuing education of healthcare workers. My interpretation is that only guidelines have not been issued. I don't think it states anywhere that one cannot do research, one cannot evaluate continuing education of healthcare providers. Again, it is silent on whether one can provide consultations outside the jurisdiction of India. I want to spend 2 minutes on a judgment of the Mumbai High Court, which according to me caused major problems for those of us in teleconsultation. This was because a learned judge of the Mumbai High Court had questioned why a doctor gave a consultation or not a consultation, sorry, gave an advice on a telephone and told the pharmacist to start certain medication without ascertaining for himself of the condition of the patient at that time. The judge was absolutely right. I think any doctor who gives orders to a pharmacist to prescribe medication, maybe he had seen the patient a few hours ago, a few days ago, is committing malpractice. And here again, it must be clearly understood that this telephonic consultation, which was highlighted in the media left, right, and center, was only incidental to the outcome of the judgment. So I think that now it is very clear. The practice guidelines tell you at the bottom line is patient's interest, patient interest, patient interest. Never do anything, email, telephone, video, whatever it is, if you do not think it is in the best interest of the patient. Now, how are we going to enforce these guidelines? These guidelines can be enforced. The government has been extremely good. They have also given the patient's right. A patient today has a right to go to a medical council and say, you have violated the telemedicine practice guidelines, A, B, C, D, E, etc. So please remember, I would like to mention again and again. Now, I'm just going to give my own personal experience from 1975 to 2017, when I was an active neurosurgical practice, 42 years. I have not had a single adverse complaint made against me. Not because adverse results did not appear. Certainly, and I remember at least half a dozen instances where I think I was squarely to blame for the adverse result. But no patient, I repeat, and there are enough scientific studies which document this, 97% of people who go to a court, who complain against the doctor, go to court, not because of the adverse result, but because the treating doctor did not identify himself or herself with the patient. You need to be empathetic. So long as the patient realizes that throughout the teleconsultation, whatever you did, you never did anything with a mala fide or an ulterior motive, the patient is very unlikely to go to court. And believe me, I don't think courts will take suo moto evidence of some lapse of error or some small administrative mistake which you made. I don't think the court are going to punish you for this. So please remember, tender loving care. The more the technology, the more you need to establish tender loving care with the patient to the other end, if only to ensure that he will never complain against you. I could go on and on, but I know time is a constraint. So I would like to conclude, maybe looking a little philosophical, maybe looking back at 22 years. Today, to me, this is a red letter day. Notification of the telemedicine practice guideline marks the dawn of a new era in the practice of modern medicine. The law in India is catching up with the reality and necessity of modern times. Today, a doctor can provide teleconsultation with any medium, email, phone call, message, fax, WhatsApp, LAN, WAN, etc., etc. Of course, chatbots were not specifically mentioned. Robots were not specifically mentioned. IoTM were not specifically mentioned. But I'm sure in the next edition of this guideline, all this will be mentioned. As doctors, it behoves us to follow the law. We are the cream of the cream of the cream of society. As in any democracy, we will of course draw attention of the authorities to ambiguities, lacunae, and requirement for amendments. We also need to be future ready. At present, the TMG insists that the final prescription or counseling has to be directly delivered by the registered medical practitioner, even if AI is used. There are many hospitals in India which have already started using artificial intelligence, particularly in the screening of diabetic retinopathy, cardiovascular, etc. I wonder whether a doctor can defend himself by saying, I only followed the algorithm prescribed by Google. Will Google be implicated as a party to the crime, as an accessory to the crime if I use AI? Time alone will tell us. Most important, please remember that these guidelines are not written in stone. Even a 5-bench Supreme Court judgment is being reviewed. Interpretations differ from court to court. The higher court overrules the lower court. The highest court overrules the higher court. A test case in telemedicine is required. To the best of my knowledge, in the last 22 years, we would probably have done about 30 to 40 million teleconsultations. I am not aware of a single case of teleconsultation which has come to the Consumer Protection Forum or to any court. Res ipsa loquitur. It speaks for itself. And I think we as doctors who ultimately care for the patients, that is what we have all been trained for. Let us not forget about procedural lapse at the worst. The doctor-patient relationship is critical. And I, for one, am absolutely delighted that the Board of Governors have deemed it fit to introduce the telemedicine practice guidelines so soon. It is 21 years since we embarked on telehealth. The coronavirus has added to this dramatic change. India, my dear friends, should no longer follow high standards. I believe the time has come that we must set high standards. We no longer should be striving to achieve world class. The world should strive to achieve India class. Nothing can stop an idea whose time has come. Creating awareness and convincing society that today distance is meaningless, the geography has become history, should be followed by bringing order. It is time for laws, rules, regulations, and compliance. Technology is the least important of all this. It was Confucius who remarked 2000 years ago, he said, a journey with 1,000 miles begins with the first step. I think the first step was taken at least 22 years ago. We have made reasonably good progress, but thanks to this notification, our transformation is going to be exponential growth. We are no longer going to meet the 5%, 10% incremental growth. We are going to grow 5x, 10x. I remember a couple of years ago, Dr. Pratap Reddy called me one day and he said, Ganapathy, I want 1,000 telemedicine units in 1,000 days. And I said, what does this elderly person know? Does he know how difficult it is even to make one single telemedicine unit? Sir, today I withdraw the statement which I made, and I am confident that in my lifetime, I will see not 1,000 telemedicine units, but 100,000 telemedicine units. So as Winston Churchill said, never ever let a good crisis go to waste. We will certainly beat coronavirus. An RNA strand weighing less than 30,000 ATCG, the RNA strand, a country of 1.3 billion people are not going to be beaten by a small RNA strand. And I think the telehealth is going to help us in a long, long way. Thank you once again. Thank you, Chime Foundation. Thank you, Tamil Nadu branch. Before I conclude, I just want to one small sales pitch, which I think is equally important. And what happened to that last slide? I wanted to show one slide. Okay, sorry, this is my last slide. I couldn't resist the temptation of showing this. Please register for this free introductory online TSC telemedicine webinar. The MCI have requested us to cover 500,000 people. I would like to cover at least 3,000 people. We are starting this in 48 hours from now. Please register. Thank you once again. If there are any questions to answer, I'll be happy to take them.
Thank you, Professor Ganapathy. This was indeed a very useful session to all of us. I saw one question on the chat window. If a person is outside India, if a doctor is outside India, can he still provide telemedicine consultation? If there are other questions, members can please raise their hands.
The answer to this question is very simple. All the questions which I have been asked in the last 20 years, the answer I gave was very simple. I don't know. So same thing, sir. Answer is I don't know. But we have noted this as a point. This will be brought to the notice of the Board of Governors and a clarification obtained. At the moment, we don't know.
If any other participants have any questions, you may please raise your hand on the chat window and we will have you unmuted and you can go through your questions. Keep your questions short, please. Anybody with a question?
Hello.
Yeah, I have written a couple of questions in the chat window for Dr. Ganapathy.
Dr. Kananveer, if you can relate your questions, doctor will have.
I'm not able to. Can you read it, or I don't know where is the chat?
Chat window. They're in the chat window.
Dr. Kananveer, can you relate the questions and we'll have an answer.
Sorry, I'm not able to see this here.
Sure. So, Dr. Ganapathy, you said that doctors should always maintain a record of the teleconsult. Now, most teleconsultations are actually via phone call, not necessarily via video. So in such a case, how does the doctor maintain a record?
No, very simple. When I say maintain a record, we don't mean from start to finish. Just say 11. I'm sure you already have it. 11:45. Somebody from Tirunelveli, Mr. Rama Subramaniam, called me. I gave this was for 5 minutes. You devise your own method of doing it. Just 3 minutes. 5 words, 6 words, 8 words.
No, but write it where the patient's records are not with you, so you cannot write in the patient's.
No. You just say bronchial asthma. I did a telephonic consultation for bronchial asthma for Mr. Sriram. Query bronchial asthma, whatever it is. At the moment, see, all these is going to take several months. Ideally, one of the methods is to have an EMR on your phone. All this will take time. At the transition period, you just need to maintain that you gave a consultation with a working clinical diagnosis, name of the person. That is all.
One of the questions I have is about the definition of RMP. Does that include nurses?
No, this is very clear. This is an amendment to the Medical Council of India Act. Registered medical practitioner, registered either with the state medical council or directly with the Medical Council of India. There's no ambiguity whatsoever. Only Medical Council of India. But I understand that Ayush has already been approached, and we expect in a couple of weeks, homeopathy, Unani, Siddha, all that notifications will follow from their respective councils, perhaps from the nursing council also. But this very clearly states only those registered with the medical council.
So can I ask a question?
Yes, please.
Yeah, this is from Kerala. The Travancore Cochin Medical Council, they have notified that this should be only for routine follow-up. It should be for minor ailments. And they have also notified that the PDF of the consultation should be sent to the Travancore Cochin Medical Council after this thing is over. And last, the TCMC may at any point of time withdraw this order without prior notice, and this order will automatically be cancelled once the normalcy attained in the state of Kerala, enabling regular consultation and practice. So what does
sir, I am not honestly competent to adjudicate between the government of India and the Travancore Medical Council. That's far beyond my this thing. But having said that, I mean, I think what I would do as if I were practicing in Kerala is I will do what I think is in the best interest of the patient. That is all. I am not too much bothered about this nitty-gritty. There is a notification issued by the Ministry of Health, Government of India. Of course, health is a state subject. I honestly don't know, but I would request you to please bring this to the notice
of the Secretary, Telemedicine Society of India, please send us a detailed note. We will certainly include it in the various points which we intend to bring up with the Board of Governors.
Thank you.
Dr. Ganapathy.
Hello. Sir, Dr. Ganapathy, about taking the consent of the patient prior to teleconsultation. Is it just sufficient that the patient calling to the health worker or the consulting doctor is sufficient as a proof to show that he has given his consent, or we have to prompt the patient to record his consent as an audio file, for example, in a WhatsApp call?
The guidelines state that when a patient directly calls the doctor, initiates the teleconsultation, no specific extra additional consultation, written consultation need is required. For example, when I come to meet you face to face, it's an implied consent. You don't get a consent form for me when I come and tell you I've got headache or back pain, isn't it? So the same thing. It doesn't matter if it's teleconsultation. However, if the consultation is initiated by a relative or by a member of the healthcare system, not the patient, in that case, you need some evidence. It can be very informal evidence that the patient is aware that his doctor or his mother or brother or sister or whatever it is contacting you for a consultation.
We can go for one last question.
Yes, please.
Can I ask a question?
Yes, please.
Video consultation is superior to all modes of consultation.
Zoom. Hello.
Yes, go ahead, please. Go ahead with your question.
Yeah, currently we are using Zoom app for the consultation. Recently, there were some problem with Zoom app data security. They were selling the data to Facebook, or there was also concern that their end-to-end video recording is not encrypted. So can we use this?
Sir, I don't think, see, most of the questions are in twilight areas where obviously we do not have an answer. But the guiding principle, and I'm very sure of this, the guiding principle is patient interest, patient interest, patient interest. Particularly in the face of a pandemic, I mean, to use unparliamentary language, I'll say to hell with all these things. I am interested in ensuring that the coronavirus spread is reduced. I want to flatten the curve. So I think that is the primary, secondary, tertiary, and quaternary care which we do. Or let the crisis tide over. We'll note down all the points which you have mentioned. It may take a couple of months. Please understand that it took several years before these guidelines were actually notified. So I really don't think we should bother too much about what type of encryption is being done, etc., etc. This is what is important. This is my personal opinion. I may be totally wrong.
Thank you, everybody, for attending today's session. In the interest of time, we will not take any more questions. It's definitely thank you very much to Dr. Ganapathy. I think I must say one thing at this point. Behind every successful telemedicine practitioner, there is a lady recording him and making sure that his lecture goes right. Thank you, Mrs. Vijayalakshmi Ganapathy, for joining us. We couldn't help notice that you are also part of it. Thank you very much for joining us today. Thank you, Professor Ganapathy, once again. Thank you, members of the Telemedicine Society of India. And thank you, Chime India members. Have a good night. Stay safe, stay at home, and let's flatten the curve.
Thank you, Arvind. In fact, she prepared the slides. Though I made the content, the slides were prepared by her.
Thank you, Doctor. Thank you, Arvind. Thank you, everyone. Bye-bye.
Thank you, Arvind. Thank you. Bye.
Bye.
Thank you, everyone. Thank you.